So it looks like we still have some people joining, but I think we're going to go ahead and get started. So hello and welcome to how to change opioid prescribing in primary care using a systems-based approach. And this is the Washington OD2A peer-to-peer webinar series, and we're really excited because this is our first one. So thank you for showing up today. So just to let you know about our future webinars that we have, they're going to be on the fourth Tuesday of the month, 10 a.m. And they will be running from January through July. And our style is anticipated to be a 20-minute presentation followed by facilitated peer discussion. And we really would like to use this time to facilitate discussion among all of these OD2A programs across multiple states and just create a culture of collaboration. And here are a few upcoming topics starting in February. Our next topic is learning from each other, optimizing the use of the prescription drug monitoring program. And if you have any other ideas for us, we'd love to hear those. And just a reminder, we do have the chat available. So if you'd like to go ahead and introduce yourself via the chat, that would be great. Or if you have any questions, please know that you can use the chat at any time. Here is our agenda for today. We're going to start off by introducing the Washington OD2A team, the 6 building blocks, and then we're going to dive into what do we mean by a systems-based approach, and then we're going to tell you more about the 6 building blocks, and then continue with discussion in breakout sessions, followed by some sharing from all the different groups. So I'd like to give an opportunity for our team just to give some brief introductions about who we are. So I can start with myself. My name is Ashley Johnson, and I'm a practice facilitator and research scientist here at the University of Washington. And I work with this great team, as you can see on the board here. So I can pass it over to Katie if you want to continue with introductions.
Good morning / afternoon, everyone, depending where you are. My name is Katie Osterhag. I'm top left up there on your screen. I do similar things with Ashley. So I work with clinics around our state related to prescribing in line with evidence as well as policies. So I'm looking forward to learning from you all today. And I guess I can popcorn it over. Let's see, I'll popcorn it over to Sharon.
Hi all, I'm Sharon Garrett. I'm probably the newest member of the team here. I just started last week, but I will be taking on some of the project management responsibilities, and I'm excited to learn more. Kelly, do you want to go next?
Sure. So I'm Kelly Ehrlich. I'm far right, second row. I also am a project manager. I've been working with the 6 building block team since the beginning. This started as an HRQ project to develop a systems-based approach to helping primary care practices improve their opioid prescribing practices. So it's been really fun to see it get to this point and to be able to really spread our ideas and help others grow new programs. I'm sending it to Laura May.
Oh, I think Laura May is actually on mute for the time being. So I think Michael will pass it over to you.
Hi, everyone. Michael Parchman. Glad to be here. I'm the really intense, serious-looking person on the far right of the top-hand row. I forget what I was actually doing in this meeting where they took that photo. I actually work at Kaiser Permanente of Washington here in our research institute, and I think I said I'm a family physician, but that's who I am. So glad to be here.
And I can introduce myself now. This is Laura May Baldwin. And I, like Michael, am a family physician at the University of Washington. And alongside Michael, have developed the 6 building blocks in clinics all across Washington and Idaho, and then disseminated it past those borders across the country. So it's been a really exciting project to be a part of.
Great, thank you. All right, and now I'm gonna pass it over to Katie, who's gonna facilitate some of the welcome activities.
Okay, so to start us off and break some ice here, I want to just really clearly state there is no right or wrong answer here. So what I would love for you to do to start us off, and so whether this is you work for the state or you just live in the state, I'd love for you to take about 30 seconds and type in the chat, what are some things that you see your state doing to engage primary care practices around evidence-based opioid prescribing? So I'm going to pause for a second and I'll be quiet. And if you could just type them in there. And when you type it, if you can say what state you are, that also would be great. All right, great. Thank you for the people who have hit send so far. So I'm seeing a couple in there. Would love to hear from others who are in other states. So it looks like Katarina, who's in Southern Nevada, they're developing some academic detailing programs surrounding opioids. Katarina, can I ask you to come off of mute for a second and just to give us like a 30-second overview of what the content of those programs look like?
Sure. Hi, I hope you can hear me.
Perfect.
We, for our academic detailing program, we are currently looking and comparing PMP data and looking and seeing where the high levels of opioid prescribing are in our community, specifically where there are 2 or more opioid prescriptions per patient, or where there might be a crossover of benzodiazepines and opioids, to kind of see where those high risk for overdose are. And then we're providing primary care providers with a screening tool to determine if those opioid prescriptions are still the best option for their patients, if they're still actually helping their pain, providing them with alternate pain coping strategies for their patients, and then teaching them how to taper in case those prescriptions are not needed anymore. So just to try and kind of reduce the number of opioid prescriptions in our community and our county.
Great, thank you, Katarina. So I'm seeing a couple others. Looks like Shihu, I'm sorry if I've mispronounced it, and then Winford also, and actually Patty also saying that they do some academic detailing. Winford, I'm seeing that you have a hub and spoke model and a PDMP. Could you talk briefly about what those look like in your state?
Yes, in our state, we have part of the Louisiana State Opioid Response. We have the hub and spoke model where we go into the actual facilities.
Well, it looks like maybe we lost Winford's audio, unfortunately. Are other people having trouble hearing him? Okay. All right. Sorry about that. Let's see. Actually, it looks like Nicole had some of the similar programs in Florida. Nicole, I'm going to invite you to speak for a second, and then I think we'll go on with our presentation. So Nicole, what are some of the things that you're seeing in Florida?
Yeah, sure. Good afternoon, everyone. So yeah, we're working on the OD2A grant out of Duval County, Florida, and we'll soon be providing academic detailing to primary care clinicians in which we're seeing the highest rates of overdoses. But we'll be speaking to them about things such as the Florida prescribing rules, and really just how to interpret the reports that are available to them within the system to help inform their patient care.
Great, thank you for sharing. All right, well, thank you for everybody who typed in here, and I would love to encourage you. So we're gonna share a little bit about our program now, but when we break into some groups, to continue sharing some examples from your own state so that we can all learn from each other, because that's, I think, our biggest goal for today. So I will go ahead and pass it back over, and I believe to Michael or Dr. Parchman.
Thank you, Katie, really appreciate it. Can everybody hear me okay? I see heads nodding. Okay. So what do we mean by a systems-based approach? So as a family physician, I know that in the clinics that I've worked in throughout my career, there are systems in place that help us get our work done on a day-to-day basis that help all of us get out the door in time to have dinner with our families in the evening. Whether those systems be our refill systems, whether those systems be our check-in processes, whether those systems be how we handle messaging from patients, my inbox that gets filled up with patients asking questions, the actual care processes, how we get immunizations done in our clinics. All of those are clinic systems. Our goal in this work that we've been doing now for 6 years was to create a structure within help clinics create a structure that makes it easier to offer evidence-based chronic pain care to patients, especially those who are on long-term opioids for their chronic pain. So this work began actually 6 or 7 years ago. And so examples of system-based activities for chronic pain with opioids is having a uniform clinic policy about opioid prescribing, having workflows for patients who are on opioids about things that need to be followed or checked, training staff on patient-centered language and shared decision-making, and then developing systems within your clinic so you can actually track the patient population who are on opioids to say, when was the last time someone checked their PDMP? Or, when was the last time they had a urine drug screen? Maybe it's time for one. So that's what we mean by systems-based care within primary care clinics. And the program that we're going to describe to you was a path or a roadmap or a guide for areas of work that clinics need to do to develop these systems in their clinics. So next slide. And that's this program called 6 Building Blocks. So system-based changes for opioid prescribing. So next slide. We've been partnering with our Department of Health now for several years to work with clinics to roll this program out across our state. We primarily do it through a practice coaching or practice facilitation model, not so much academic detailing, because we believe if you create structures and operational structures within clinics to do the right thing, clinicians want to do the right thing. It's just that they don't have systems in place that support them in doing the right thing. So, and we also train other QI, quality improvement personnel throughout our state and how they can do this in their own organization. So they can be that QI expert, that practice coach, that practice facilitator to make these changes in their clinic. So next slide. So this was the original publication about where these 6 areas of work that we call building blocks came from, describing these. They were actually developed as part of a large project to look at team-based care and primary care across the United States. So if you go to the next slide, you can see these are the sites that we visited. We actually did a 1-week visit in each of these primary care clinic locations to look at team-based care. And one of the things we began noticing about team-based care early on in these clinics is they all had a similar approach to addressing opioid prescribing for patients with chronic pain. And we began collecting observations about how they did that. And those we distilled into these 6 building blocks. These are the common areas of work that all these clinics did in order to get their arms around the overuse, the overprescribing of opioids for chronic pain. So next slide. And these are the areas of work. So you had to have leadership engaged and have a consensus about this is a priority. You had to have some work around our policies. This is how we do things here. This is what all of us agree is standard of care. Here are patient agreements that we all agree. Patients need to agree this is their responsibility. This is what our responsibility is for the patient. We need to have common workflows to get the work done. We need to have tracking and monitoring systems to track this patient population. We need to learn how to do planned patient-centered visits ahead of time before patients actually come in. And we need to develop resources for patients with complex needs. And finally, we need to be able to measure what we're doing and say, is what we're doing making any difference? Is it improving things? You may say, well, this is just common sense QI work, but it actually is very relevant to opioid prescribing and to patients with chronic pain. So these were the 6 areas of work that we call 6 building blocks. So next slide. And this is the way we did it. It was a facilitated approach, so we call it practice facilitation. So each clinic has a coach, and the people that are on the call today, Ashley, Brooke, Katie, are all practice facilitation experts. They've all worked with clinics to help them do this work. They're the ones who check in with the clinic every month to find out where they are on their journey about improving evidence-based opioid prescribing. And typically the facilitators have kind of phases of the work of supporting. So initially they're helping the clinics prepare to launch the initiative. And the next stage, they're actually making the changes in the clinic. They're designing and implementing changes in workflow, revised policies, tracking and monitoring systems. And then in the last phase, they're saying what worked and what do we want to keep? And how do we make sure we don't forget about it? How do we sustain this in our clinic over time? So next slide. So clinics did things like they offered clinical education opportunities to staff and clinicians about our current science and understanding of what is chronic pain. They wrote and implemented a workflow for patients who have chronic pain for appointments to make sure all the screening was done. So they had their PHQ-9, their GAD-7, their PTSD screeners, everything done that they thought was important to screen for. They created dashboards that were measures they could follow of changes in their clinic that were important to them. And they developed chronic pain visit templates within their EHR to make sure they were covering key elements of the visit outlined in the revised policy. And then they all got together, everybody in the team, the front desk staff, the medical assistants, the nursing staff, the billing staff, the clinicians, and they all said, do we all agree this is what we all ought to be doing? Yes, okay. Who's gonna do what? Let's delegate the work across the team. Front desk staff, what can you do? MAs, what can you do? Administrative staff, what can you do? Nursing staff, what can you do? Clinicians, what's your responsibility? So they figured out how they could delegate it so that everybody was taking a piece of the work and it didn't all fall on the back of the clinicians. So next slide. And this is what happened in the original study we did. There were 20 clinic sites. All of them were rural clinics. These were 6 rural organizations that had 20 clinic sites. And you can see a decline in the number of patients who are on opioids, and you can see a decline in the % of patients who are on higher dose opioids. If you go to that link, it'll take you to the actual manuscript that shows you the comparison to the control group and the statistical analysis we did that showed significant differences between the clinics enrolled in the study and the control group of clinics. So you can see that the outcomes were improved in the clinics that were doing this work. And more importantly to me, or just as important, I wouldn't say more important, we heard from the clinicians and staff that they were really happy about how their work life improved. They felt more confident and comfortable taking care of their chronic pain patients. They felt less stress. There was less drama in the clinic in providing care to patients. It improved their relationships with patients using long-term opioid therapy. And I'll just make one other comment, especially to this audience, which is we saw several of these clinics, we saw providers, clinicians get interested in getting an X waiver to prescribe buprenorphine. And they would have not touched that with a 20-foot pole before they started this work. But once they got into this work and improving care and got more comfortable and confident with it, they started recognizing they had patients who needed buprenorphine. And they were in rural areas and there was no one available to do that. And so they were going after getting their X waiver themselves. So this program turned out to be an on-ramp for them to set up buprenorphine programs for patients with opioid use disorder. So next slide. And there are a lot of resources on our website. So you can go to improvingopioidcare.org. So you can go there and find a lot of resources for clinics, model policies, model agreements, scripts for difficult conversations with patients. There's a setting up a buprenorphine program in your clinic resource. COVID, impact of COVID on chronic pain care and telehealth. So a lot of resources there for everybody to look at if you want to look at improvingopioidcare.org. And I think that's about the end of it. Is there another slide? Yep. Nope, I'm done. Okay, I'm going to pass the baton back to Ashley.
Great. Thank you, Michael. So now we are going to take some time and break into these breakout groups to have some more in-depth discussion. So the aims are here, and here are the discussion questions, and a member from our team will also be joining each of the groups to help facilitate those discussions. So we'll have about 20 minutes for this. So I will see you.
Look forward to hearing what was said. All right, so now that we're back together with the whole group, I want to start us off just by hearing from everybody. And so this can be a show of hands, either like actually raising it in your video if you have it on, or in your reactions. And reminder for those, this is down there on the bottom of your screen under reactions. You can click one of those. So just show of hands, who is seeing systems-based approaches incorporated through their work right now? I know there's got to be more than that because I just heard about them in my group. All right. Okay, so in the group that I was in, one of the things that I neglected to do was to, on the front end, ask somebody that would be the person that wants to come back and share. So maybe the other group did that, what they were supposed to do. Is there anybody that from, I guess, the group that was not the one that I was in that would like to start us off about what were some interesting things that you heard about systems-based approaches happening in your group?
Hi, this is Victoria Pless. I am actually a representative from ASTO, but I was the note taker so I could let everyone else have the discussions. So in our group, and everyone, please feel free to jump in if I miss something, but there are systems-wide approaches happening in states, and they are broad, and they are also at times maybe on pause right now because of COVID. So while there were big plans to maybe get things off the ground and keep things moving because of COVID and the ongoing pandemic, they are maybe paused, but are also, continuing to build up their plans. So once the time comes that, you can continue to have provider meetings in person, or you can kind of be a little bit more innovative and execute the things that you had planned, everyone will be ready. Working with lots of different partners, providers, medical examiners, law enforcement, other sorts of prevention partners to make sure that we're getting all the information to make sure that these system-wide approaches go off smoothly. There is also discussions around some of the resources from 6 blocks that could be used in some areas where people are trying to figure those things out. and also had some discussions around co-prescribing naloxone and how that has been successful, and really just encouraging all different kinds of partners to utilize that in their efforts with opioid prescribing. And group, feel free to jump in if there is anything else that you wanted to highlight.
You did awesome.
Thanks for note taking, Victoria. That was perfect.
Thank you so much, Victoria. All right, so is there somebody that was in that second group who wants to just, you know, take pity on me since I forgot to ask you to do this, and jump in and say what you heard from what Victoria said that was similar or different to what we were talking about in our group? Nobody's going to take pity on me, huh? Oh, Laura May, you are on mute.
I'll take pity on you if you'd like.
Well, thank you.
One of the things that struck me in our group was, well, first of all, there were many, many systems-based approaches that I think were being taken, but they look different because they're not necessarily in primary care practice. Many of those were the use of data to identify particular target populations for programs. I was struck by how pervasive academic detailing is as a strategy across the programs that were represented in our program. And I was also struck by as the first person spoke, the impact that COVID has had on all of these programs. I mean, that was really a pretty dominating theme. And we talked a little bit about how some programs have tried to shift to different kinds of strategies that can be implemented during COVID, like instead of one-on-one academic detailing, shifting to community conferences and things like that. There was also a concern, I think, about, you know, is it even possible to take on a practice-based, systems-based approach right now, given the competing demand of COVID? And that was really, really difficult, as opposed to a 15-minute conversation that seemed a bit more doable with academic detailing. I think that I was really struck by the question of, you know, if you could dream in your state, what would you like to see? And I loved the answer, which I think was uniform across the participants, which is getting various departments to collaborate. How can we get partnerships to work so that we can actually get our programs to collaborate effectively and then get the services to the people in need? And that spanned, you know, just different types of departments across within departments of health. It also spanned data sharing and how to make sure that the PDMP is collaborating with those that are trying to implement programs. So those were a couple of the things that I noticed. I don't know if others in our group want to add anything.
If not, I think I really briefly want to give the folks that are across the two different groups, is there anything that you heard in what Victoria and Laura May just shared that you would want to ask to hear a little bit more about? And belated thank you for Victoria and Laura May for sharing. All right, I'm seeing folks saying that looked like it represented the discussion. Thank you.
Yeah, I will say that academic detailing came up several times in our group as well as a common approach. But again, it's been difficult to get the attention of prescribers because of the COVID epidemic. So, yeah.
Okay, well, I think I'm going to probably pause this part of the conversation here and ask Ashley, will you move us forward to the next slide? First, we just want to thank you very much for joining for today. A reminder for you that the next webinar we have scheduled is Tuesday, February 23rd, 10 a.m. Pacific, so I guess that makes it 1 p.m. Eastern. And we're going to be talking and really diving into the PDMP. So would love if you can join us for that. And Ashley, do you want to say anything else about details of how folks can register for that?
Yeah, just the same way that you registered for this webinar on the OD2A technical assistance website, on the calendar will be the Zoom registration link, and that should be active in the next couple days. So thank you again for joining, and I hope to see you next time.
Perfect. And in the interim, Ashley's going to go to the next slide that does have our contact information. So if there is anything that you want to talk about or share resources on related to how the 6 Building Blocks program does a systems-based approach, we are absolutely happy to share materials with you. So please feel free to reach out. All right. Thanks again for joining us, and we hope you all have a really great afternoon.